Thank you. It's a pleasure to introduce our next speaker, Dr. Shahid Malik. Dr. Malik is an associate professor in the Department of Gastroenterology and a transplant hepatologist here in Pittsburgh. He's going to speak to us today about Fontan-Kreutzer associated liver disease.
Thank you. It's an absolute pleasure to be here. I see quite a few Fontan patients, so I'm here to share my thoughts and to learn. So the last time I was in a group with so many cardiologists was last week. I come from a family of cardiologists. My dad is a cardiologist. My two older brothers are cardiologists. The youngest is a pathologist, so half a doctor. So this was the proudest day of my life. Not necessarily that I had a daughter, but if you look at the bell of her stethoscope, it is instinctively placed in the right upper quadrant. So a future hepatologist. I think I took it too far when I brought her to the GI lab and I showed her where this thing is inserted. She doesn't want to be a doctor anymore. So this is my outline. I'm going to touch briefly on pathophysiology, talk about incidence, risk factors for progressive disease, clinical manifestations, liver cancer, how do we assess and predict a patient's course, and then the last half I think I'm obliged to at least touch base on transplantation. I'm going to try to do this centered around a patient case. So a 42-year-old male referred to me from cardiology for abnormal imaging and abnormal liver test. He underwent a Fontan procedure at the age of 7. Per cardiology, the heart failure team, he had NYHA class 3 and met minimal listing criterion for heart transplant. His heart transplant was unlikely to be imminent, but they needed liver clearance. So these are his labs: a mild elevation in bili, which is predominantly unconjugated, a GGT about 3 times upper limits of normal, other pertinent labs, maybe some mild thrombocytopenia. Imaging shows a clearly cirrhotic liver with dilated hepatic veins. He has scant perihepatic ascites, mild splenomegaly, and some tiny collaterals in the upper abdominal wall. So liver fibrosis following Fontan was first recognized in 1981. Some degree of fibrosis is universal within the first few years. The Fontan circulation leads to elevated pressure within the hepatic veins and sinusoids, which leads to continuous and non-pulsatile passive congestion. In turn, this compromises portal venous inflow. The liver in Fontan physiology is therefore more reliant on hepatic arterial inflow and susceptible to changes in arterial circulation. So a combination of all of these factors, pressure, blood flow, congestion, oxygenation, complement and cytokine activation, neurohormonal regulation, and even the microbiome, ultimately leads to hepatic fibrosis and portal hypertension. Abnormal liver tests are seen in 1/3 of Fontan patients. It's of course recommended that you rule out other forms of chronic liver disease, especially viral hepatitis, Hep B and Hep C. It's imperative that you counsel patients on avoiding secondary insults. You learn very quickly in liver disease 1 + 1 does not equal 2. So anything you can do to avoid specifically fatty liver and alcohol is incredibly important. Our patient, his chronic liver workup was negative, viral serologies were negative. He had a moderate alcohol history. We counseled him to stop. His BMI was 31, but there was no obvious fat seen on imaging. The development of ascites almost always prompts a liver consult. You can usually determine if it is cardiac in nature by interpretation of the fluid analysis. Typically, cardiac ascites will give you what we call a high serum albumin to ascites, or SAG gradient, and a high total protein. BMP has also very good sensitivity and specificity. Our patient did undergo a one-time TAP greater than a year ago, and his analysis was very consistent with cardiac ascites with a total protein of 5.1. The incidence of varices also in about 1/3 of patients. Bleeding, however, is uncommon. All appropriate patients should undergo a surveillance EGD. Our patient underwent an EGD and there were trace to small esophageal varices. So if you take one home message from my talk, it's probably this one. The development of advanced fibrosis or cirrhosis occurs in up to 1/2 of Fontan patients by their mid-20s. That's a relatively high incidence when you look at the other most common causes of chronic liver disease in the United States. Hepatitis C, about 1/3 of patients will develop cirrhosis in a span of 30 years. Alcohol, about 20%. Fatty liver disease, about 5 to 8%. So how do we assess degree of hepatic fibrosis? There are some emerging blood tests that have not been yet validated in Fontan patients. I'm going to be focusing on elastography and liver biopsy. More and more you will see that the use of elastography as a means of non-invasively determining hepatic fibrosis in all forms of liver disease, and there's increasing literature regarding its use in Fontan patients. So the top left is an image of a FibroScan, which we have available in our clinic. It can give you a read in about 5 minutes. The next two images are ultrasound with shear wave elastography. The nice thing about that is you also get a decent image of the liver. And then lastly is MRI. So the most accurate measure in 2023 is probably MR elastography. A measurement of 4 kilopascals is generally considered advanced fibrosis, and there is emerging data on its correlation with Fontan failure, portal hypertension, and longitudinal follow-up. Our patient had a pacemaker, so we couldn't get an MR. His ultrasound correlate was F3 fibrosis. These are MRI images with their corresponding stiffness maps below, so red indicates more fibrosis. Just as a reference, this was a patient I saw this Wednesday in clinic, a 32-year-old who likes her vodka, and you can see her KPA is an impressive 10. At the moment, however, liver biopsy remains the gold standard for the diagnosis of Fontan-associated liver disease and degree of fibrosis. But as much as we love biopsies, mainly because we're, I think, spoiled here in Pittsburgh to have some of the best liver pathologists in the country, it does have multiple issues. There's sampling error, risk of bleeding, patient comfort, and it's not suitable for longitudinal monitoring. The transjugular route especially can be challenging given the venous anatomy. So this study is the basis of what we quote when it comes to advanced disease in Fontan patients. 74 patients undergoing biopsies, median age was only 17. Over 1/3 of patients had bridging fibrosis defined as F3 or full-blown cirrhosis. Most of us will default to a transjugular liver biopsy because it allows us to obtain pressures, which of course have huge prognostic information, but this too is problematic. A lot of the time the samples are fragmented and many times they underestimate the degree of fibrosis. And the pressure measurements may not always be accurate in Fontan patients because of the presence of veno-venous collaterals. So back to our patient, he did undergo a transjugular liver biopsy. His wedge was 15, his free was 13 for a gradient of 2. So remember, portal hypertension is defined as a gradient of greater than 5. Clinically significant portal hypertension, a gradient greater than 10. His histology revealed portal to periportal fibrosis. Changes were consistent with advanced chronic congestion. There was architectural distortion. Overall, you would summarize these biopsy findings as early cirrhotic changes. Here's a representative image of his trichrome. Here I'm just highlighting the sinusoidal congestion and the hemorrhage, which is classically seen in outflow obstruction. And over here I've highlighted an area of bridging fibrosis, and you can almost make out a nodule. Hepatocellular carcinoma deserves special mention and is an increasing recognized occurrence in Fontan patients. Most of the evidence for surveillance is based on this research letter published in 2018, quoting an incidence of 1.3%. The concerning thing is that many patients are being picked up with advanced and metastatic disease, and equally disturbing, half of the patients are reportedly do not have cirrhosis. Currently, if you look at surveillance for HCC in our general liver population, it is restricted to patients that have cirrhosis. The exception, of course, is Hep B. So I think this is something we need to have more data on. What modality to use is also hugely problematic, in my opinion. This study suggests that ultrasound is probably inadequate. but as we know, MRI is not feasible in many of our patients, and subjecting them to Q6-month contrast CTs is probably not the right thing. Our patient imaging showed cirrhosis, but no obvious lesions. His alpha-fetoprotein was normal. So the evaluation and management of Fontan patients from a liver perspective is challenging and requires expertise, but is not the major issue I believe we are facing. The single biggest issue ultimately becomes the role of transplantation, namely combined heart transplant versus isolated heart transplant. This was my fortune the other day. An expert is someone that knows so much about so little. So how do we assess severity in liver disease in liver patients in general? Well, we have multiple scoring systems. The most widely used are the MELD and Childs. Of course, none of these were designed nor have they been validated for Fontan patients. How do we predict outcomes or risk assess? The two most commonly employed risk calculators are the Mayo MELD risk assessment, which incorporates the MELD score, plus the patient's etiology of cirrhosis, ASA score, and age, and the relatively newer Penn vocal score. These scores definitely have their place, but as you can see, they don't allow an input for transplantation and honestly are useless when it comes to predicting transplant outcomes. The biggest problem with these scores, in my opinion, is that they almost completely ignore portal hypertension. The other reason these scores won't bode well in cardiac and Fontan patients is because many of the parameters are just not reliable in this particular patient population. LFTs can't be used because of congestion. Albumin is depressed in 50% of heart failure patients. INR is influenced by anticoagulation. Many patients are on diuretics, which influence the kidney function. And we touch base on imaging, elastography, liver biopsy, and HVPG, and their reliability. So when should you proceed with an isolated heart versus combined? Nobody knows. There is very limited data. In fact, most centers are now defaulting to combined. Although this is a cautious and prudent and maybe easy thing to do, is this always in the patient's best interest? Combined heart transplant is a rare phenomenon, and although recently there may be a slight uptick in cases, historically they make up a tiny sliver of transplantation. With regards to combined, these are case series from the large centers of patients undergoing combined, Stanford, Penn, and Mayo, with very good outcomes. Limited data, obviously, with a total of only 25 patients. Combined liver organ transplant provides an immunological benefit, obviously, that cannot be under-recognized. Studies confirm a decreased incidence of rejection with the hypothesis that the liver confers immunotolerance and protection against rejection in the setting of multi-organ transplant. But I think the more important question is combined always necessary? Are we disadvantaging a group of patients by subjecting them to combined transplant? Unfortunately, the data on Fontan patients undergoing isolated heart transplant is also quite limited. A quick word about the pediatric population, a total of about 47 children. Outcomes are very good. So some evidence to suggest that if the patient is very young, isolated heart transplant may be okay. With regards to the adult side, there are two small single-center studies. This one from Emory, which did include a few pediatric patients. This study wanted to highlight the short-term successful outcome, but also the radiographic improvement visualized in the liver before and after transplantation, which is impressive. This study is from the Toronto group. 14 adult patients undergoing isolated heart transplant with a follow-up of 5 years. 4 died within the first year. 8 were alive at 5-year follow-up. So I don't know if these two studies make you feel better. I think the bottom line is there probably is a subset of patients with advanced fibrosis who are okay to undergo isolated heart transplant, but we need to do a better job of teasing this group out. I personally think this is the most difficult question we are asked as liver specialists. Data is limited. There are 0 validated guidelines. There's differing opinions, and the stakes are obviously incredibly high. Nobody wants to be dealing with a failing liver following a heart transplant. This is the face I get every time I get asked by my cardiology or pulmonary folks to clear a patient for transplantation. Our patient was deemed too high risk for isolated heart. He's currently listed for combined. I'm not necessarily convinced he needs a liver, but again, these are difficult battles, I think, to fight. It is my opinion that one score or measurement is not enough. You need experience and must review everything: exam, labs, imaging, biopsy, endoscopy, pressure, and then you kind of get a gestalt on how the patient should proceed, but we must be more systematic about our approach. I've been helping the lung group come up with an algorithm for their patients with cirrhosis, and I labeled it the PENCEPT score. We're hoping to get this published soon. So this is my proposal for Fontan patients. I'm unveiling it today. So it is called the PESFEC score, Pittsburgh Exclusionary Score for Fontan patients undergoing evaluation for cardiac transplantation. Trust me, this score is anything but perfect. But here it is. So what you do is you exclude isolated heart transplant if you have any of these 10 things. So high sag ascites with a total protein less than 2.5, SPP, HRS, portal pulmonary hypertension, HPS, medium to large esophageal varices or prior variceal bleed, history of encephalopathy, HCC. Now, this is not that complicated. This is basic stuff for a transplant hepatologist, but here's where it gets a little intriguing. I'm proposing the addition of shunt presence on imaging. I don't have a lot of time to delve deep into this, but there is very strong data on measuring shunts on cross-sectional imaging and the correlation to outcome in liver patients. The other thing I think we need to do specific to Fontan patients is revisit the HVPG. HVPG data and transplant is extrapolated from liver patients with Hep C undergoing kidney transplantation, and historically a cutoff of 10 has been used to determine the safety of isolated kidney versus simultaneous liver-kidney. The problem is the presence of collaterals in the Fontan patient. So if you get a value of less than 10, are you going to feel comfortable saying that this patient does not have portal hypertension? I think we need to start incorporating direct portal vein measurements. So what I'm proposing is a transhepatic approach via IR, and a pressure greater than 10 directly in the portal vein would exclude a patient from an isolated transplant. This needs to be studied, obviously. I'm proposing we obtain HVPGs and direct portal vein measurements in about 10 Fontan patients and determine the correlation or disconcordance between these measurements. So this would be a transhepatic approach to portal vein. So that's my algorithm. You got to look at everything, review everything ad nauseum. I have some work to do. I'm not sure when this will fully come out, but I realize there will be some more talks on Fontan and liver transplant. I'm hoping, some of these ideas will be a springboard and perhaps some future collaborations. So my top 10 take-home points: Fontan-associated liver disease is universal. Advanced disease occurs in up to 50% of patients by the age of 30. You must rule out other forms of chronic liver disease. You must avoid secondary insults. The role of elastography is expanding, but biopsy remains the gold standard. Biopsy and HVPG have their issues. Surveillance portal hypertension, EGD, must be performed in patients with advanced fibrosis. Surveillance of HCC should probably be performed. When to proceed with isolated versus combined remains unknown. And 10, I'm proposing an exclusionary score with the addition of direct portal vein measurements. Thank you.